I'm Katie Hubble. I'm a registered nurse here at Good Shepherd's Cardiac Rehab. In today's class, we're going to talk about the overview of coronary artery disease and the anatomy of the heart. You have to understand how the heart works in order to understand the disease process. Here we go. So the overview of coronary artery disease. A couple interesting facts about the heart. The heart is a muscle and it is made up of 4 chambers. They pump blood to the lungs and to the body, supplying oxygen and nutrients. The weight is approximately 7 to 15 ounces, and it's about the size of your fist. It lays kind of in the center of your chest, slightly to the left. Average beats 100,000 times per day and pumps approximately 2,000 gallons of blood per day. That's a pretty hard working pump. Now, the strength of your heart muscle depends on the oxygen and nutrients it's receiving from the coronary arteries, okay? So not only is the heart supplying blood, oxygen, nutrients to your body, it's also supplying blood, oxygen, and nutrients to itself through the coronary arteries, okay? So the coronary arteries are like the fuel lines for the heart muscle. Now, if you have a healthy coronary artery, then they're going to be nice and strong. They're going to be elastic and flexible so that when you exert yourself, they can expand and open up to meet that extra demand, extra blood flow, and extra oxygen that's needed for your body and your muscles. This diagram shows you the heart. We're just looking at the front of the heart, kind of opened it up, so we're looking at the inside. And you can see the 4 chambers that we mentioned. You have the right atrium, the right ventricle, the left atrium, and the left ventricle. Now, in between each of these chambers, you'll see here these valves, okay, with the little stringy things here. This is a tricuspid valve on the right side. Over here, you have a mitral valve on the left. You have a pulmonary valve that actually goes out to the pulmonary artery to the lungs. And the aortic valve is kind of hidden back here, but this goes out to the aorta, okay? So these valves open and close as your heart contracts to keep the blood flow moving forward, okay? So the reasoning of these closing is to stop the blood from backflowing. If you have blood that's leaking, if you have a leaky valve, or the valve's not closing completely, then you'll get a little bit of backflow of the blood and not as much blood is pushed out to the body, okay? So we hope we have nice, healthy valves. Now the next diagram here shows you the flow of blood through the heart muscle, okay? So say you're receiving blood that's been used up, it's, needs more oxygen, it's coming back from the body all used. It's going to come in through the inferior vena cava to the right atrium or through the superior vena cava to the right atrium. Okay? So the first stop is the right atrium. Then it travels through the tricuspid valve into the right ventricle. From the right ventricle, it's going to go through the pulmonary valve out to the lungs. Now this is where it's picking up oxygen and nutrients. Once that blood is in the lungs, that's where it's picking up the oxygen and nutrients, and it's delivered back to the heart through the pulmonary veins into the left atrium. All right, so now we have oxygenated blood. Then it's going to go through the mitral valve to the left ventricle. And from the left ventricle, it's going to be pushed out the aortic valve through up to your aorta, and that goes out to your body. So this is how it's pushing blood out to the body that's oxygenated through the aorta. So to kind of help you understand, the blood flow is coming into the right side of your heart, it's deoxygenated, then it's being sent to the lungs, it's coming back from the lungs, and then it's going through the left side of the heart, oxygenated, and out to the body. All right, so not only is your heart sending blood to your body, but it's also sending it to itself, right? It needs oxygen and nutrients as well. And it does that through the coronary arteries. The coronary arteries come off of the aorta, okay? So once the oxygenated blood is pushed into the aorta, then it's going to be sent out to the body as well as to the coronary arteries. You have a right coronary artery, and then you have a left coronary artery. Now the left coronary artery will divide into the circumflex, which actually kind of wraps around the back of the heart, feeding the back of the heart muscle. And then you have the left anterior descending artery that's feeding this area down here. So these arteries, remember, we want them to be nice, strong, elastic, and flexible, okay? They're feeding, they're the fuel lines for the heart muscle. So coronary artery disease, also known as arteriosclerosis, they're hardening of the arteries. It's just a buildup of sticky plaque inside of those coronary arteries. Okay, so we're not talking about the inside of the heart, we're talking about the inside of the arteries that feed the heart muscle. So once you start to develop plaque buildup inside those arteries, then you have coronary artery disease. So in this diagram here, you'll see a nice normal coronary artery. So blood flow can flow through this artery nice and easy, right? It's open, there's nothing slowing it down. Well, now in this arteriosclerosis, you can see the plaque buildup, this yellow plaque buildup. Now look at how narrow of an area the blood has to flow through. That's going to slow that blood flow down. The more plaque you build up, the less blood flow you're going to receive to your heart. Okay, so as that increases in severity, your symptoms will increase with severity as well. Okay, now this plaque can rupture. That is when you see more of a sudden heart attack. When your plaque ruptures, your body thinks of it as an injury and sends a blood clot out to heal it. Unfortunately, this blood clot is not always helpful. It can actually completely block the blood flow to the heart muscle. Okay? Now when this happens and you no longer have blood flow to the heart muscle, anything below that blocked area is going to die. All right? It will start to degenerate. And this heart muscle shows you on the picture here, it's kind of darkened. The blockage being in the black circle. Anything below this blockage that this artery is feeding is starting to die. Now, heart muscle does not regenerate like skeletal muscle, okay? So once this is gone, it's gone. There's no way that will come back. So now you have damage to your heart, you have a weaker heart, and that's never going to come back. That's why it's so important when you do have symptoms, you go get checked, because the faster that we can open the blocked area, hopefully we can save this heart muscle. But if you don't seek medical attention right away, that heart muscle most likely will die. Now, the process of arteriosclerosis doesn't happen overnight. It actually starts in childhood, and it is progressing throughout your lifetime. Okay, so as we age, we're actually building up more and more plaque in our arteries. So what causes coronary artery disease? Well, lots and lots of causes. Basically, we're damaging the inside of the coronary artery and building plaque buildup. Now, some people might have a few causes, some others might have all the causes, some might just have one. It just depends on the person. I have a lot of people tell me, hey, this person ate healthy and they exercise and they still had a heart attack. And yes, that can happen because there are factors that can cause a heart attack that we have no control of. But had they not been doing those things, they would have had a heart attack a lot sooner. So they actually have been able to slow the process down by doing the healthy lifestyle, okay? Tobacco smoke causes heart disease. It actually doubles your risk of heart disease. Elevated levels of cholesterol actually deposit plaque into your arteries. So when you have excess cholesterol, it's getting deposited in the artery. High blood pressure can cause coronary artery disease because the high pressure against the artery wall is actually causing that artery to become hardened and stiff, so it no longer can open up and meet that extra demand when you exert yourself, okay? So that's another issue. Family history is huge. That's one of the factors we cannot control. Family history, genetics, we just get to thank our parents for that. We're born with it, and it's going to be there with us, no matter what. Age and gender are also a cause that we cannot control. Unless you find the fountain of youth, then let me know. And diabetes. Diabetes is one that we can control. You can control your blood sugars, and that is very helpful in preventing heart disease. A lot of diabetic patients, or a lot of heart patients, have diabetes, and that's what's led to it. Also, sedentary lifestyle can lead to coronary artery disease and stress. Okay, so in the next class that we have on risk factors of heart disease, we're going to discuss all these in full and get into more detail about each and every one of them. On this diagram, remember I mentioned how the plaque can rupture? This is a good picture of showing you how that happens and blood clots form, decreasing that blood flow. So any damage to the inner lining of this coronary artery is going to cause it to be rough. Now, plaque is going to stick to a rough surface more so than it would in a smooth surface. So you're going to build up plaque faster if you have a rough surface in those arteries. Angina, or chest pain. So that is the well-known symptom for a heart attack, right? Is chest pain, but it's not always chest pain, okay? This is the way that your heart is sending you a signal saying, hey, I'm not getting the oxygen I need, something's wrong, and it's sending that signal of pain to tell you, okay? So there are many different symptoms than just chest pain. You could have pain in your shoulders, you could have pain in your back, you could have pain running down your arms, your right arm, your left arm, or both arms. You can have pain in your neck or your jaw, or maybe just numbness in your jaw. You can have nausea, heartburn, indigestion, and that's a pretty common one that people put off seeking help because they think it's heartburn and they just ignore it. Believe me, any doctor would rather you go in and get checked and say, yes, it's heartburn, than for you not to get checked and it be heart-related and you end up losing heart muscle. So that's nausea, heartburn, and indigestion are also common in women. So just be aware of that symptom. Weakness, shortness of breath. You might just have increased shortness of breath, more so than normal. Something's just not off. You always want to trust that gut feeling you have. Or you could just feel like your heart is racing, having a really rapid heart rate or irregular beats. You feel like your heart's skipping. Those can be symptoms as well. So you always want to pay attention to all these symptoms, not just chest pain. Okay? Now, diagnosing coronary artery disease, of course, we always want you to get history and physical, especially cardiac patients, okay? Yearly history and physicals are recommended, and a lot of times doctors can pick up on symptoms that you might not realize just by conversing with you and finding things out that might send up a red flag saying, hey, let's do some of the diagnostic tests just to check this out. So they will usually do an EKG, an electrocardiogram, and that is just a way of looking at your heart rhythm, okay? It's looking at your beat how fast it's beating. It's looking at if you're in a normal sinus rhythm or if you're in an irregular heart rhythm. It's looking to see if you're having premature beats. It's looking at a waveform that can at times show if you are having a heart attack, not always. But that's usually their first step. Then if you go to the ER and you are having symptoms of a heart attack, they're going to do blood tests. They will draw what they call a troponin, and that troponin is an enzyme that is released by the heart as it starts to die and is not receiving the oxygen it needs. It releases this enzyme into your blood flow. So they'll draw this blood, they'll check your enzyme level, your troponin level, and then a little bit later they'll draw more and they'll compare the two to see is that troponin level increasing or not. And that is a definite way to say yes, if it's increasing, you are currently having a heart attack. A lot of times that might not be the case. They might say, oh, troponins are normal, you're not having a heart attack, you're fine. But please be aware that just because the ER said you're not having a heart attack and that you're fine, you still should follow up with your cardiologist, because it is possible that you have enough plaque buildup that you're starting to have these symptoms that are going to lead to a heart attack if you don't intervene, okay? So always follow up with your cardiologist just to make sure. They can always run more tests. Exercise stress test, treadmill test, or exercise tolerance tests. It's all the same test, just different names. This is going to show how your heart deals with the extra demand of exertion, okay? Is your heart able to accommodate that demand? If so, how well can it accommodate that demand? If you're unable to do it on a treadmill, then they can give you a medication that makes your heart think it's working out and your heart race and get this warm blush throughout your body. So that's always possible if you're not able to do a treadmill stress test. But it does give them a lot of good information about how your heart is responding to that extra demand. They can do a Holter monitoring, which is just simply an echocardiogram that is done at home. Okay, so they're going to have the sticky leads all over you. It can be ordered from 24 hours up to 2-3 month period of time. And what they're looking at is your heart rhythm. So when they take an EKG in the hospital, they're looking at a 6-second strip, okay? It's only 6 seconds, that's it. So they don't really see if something's changing and if your rhythms are changing in and out of different rhythms. They're just looking at that moment. So the Holter monitoring gives them a much better idea of what's going on over a long period of time. Then we have an echocardiogram. The echocardiogram is like an ultrasound. It's where they put that lovely cold gel in your chest, and then they're moving the thing around. What they're doing is they're looking at a lot of things. They're looking at your coronary arteries, and they're looking at the blood flow through your heart. They're checking your valves to see that they're functioning properly. They're measuring lots of different pressures inside your heart and volumes. So it's a very good test for a lot of information. But the most definitive test is the heart catheterization. So the heart catheterization is an invasive procedure. That's why they don't do it first, because invasive procedures always have, risk involved. So they always perform the other testing first. If those are positive, then they'll move to the heart catheterization. The reason it's so definitive is it's simply taking a camera. They're going in through an artery, either your groin or through your wrist, and feeding that little camera all the way into your coronary artery, okay? Then that can tell them exactly where the blockage is located and exactly how much blockage, what percentage of blockage you have, or how many different blockages you have. So that's an extremely definitive test that they will do in an emergency situation right away, but usually they'll try these other tests first if it's not an emergency. Okay, so that's it about coronary artery disease overview. It's brief, but we will get into a lot more detail with the other classes as we move on. If you have any questions, please come see me at Cardiac Rehab. Thank you.